I was preparing this talk a lot because of they're going to be, because of the young fellows and everything else. And hopefully, to many of you, I would feel great if everyone comes in here saying, God, I didn't learn a dang thing because I'm already doing it. But some of the stuff I've learned over the few years in rheumatology shows that there probably is some problems with this. I will first go to my disclosures. I'm sort of shocked to discover I'm one of the few people that has real disclosures. One of them, the Ironwood, they no longer exist, so I don't have to be a speaker for them any longer. If you look at how a patient comes into a private practice, into a primary care practice, by far the most common reason for doing it is an arthritic condition, a complaint from musculoskeletal pain, or something like that. And so this is an example of a young lady, mid-40s. She comes in and starts talking about, gosh, doctor, I have this pain here or there. I'm having soreness, stiffness, achiness. And she starts saying, what's going on? And he gives her the answer, you've got arthritis. Now, as a rheumatologist, I know we use the word arthritis a lot. And it is, it's a very important situation. If you look at this is data from 2004. So it's already 15 years old. And I can guarantee that $51 billion in costs has doubled since then. The number of people with doctor-diagnosed arthritis is now over 60 million. The number of ambulatory visits has gone up to 50 million. There are 8 million people at least, and there are at least 9,000 deaths to it. The other thing is, in people who have rheumatoid arthritis, half of them are disabled within 5 years of their disease. So this is not a benign situation. The problem is that we use the word arthritis as if it's a single disease. And I tell the patient, when someone says you have arthritis, my pet peeve is, it's sort of like saying, what do you drive? And the answer is a car. Let me see if I can get it. There you go. And obviously, like this slide shows, just saying a car shows there's a lot of differentiation. The one on the bottom right, the one with the wood fender, that actually was seen outside of Walmart in Kingsport, Tennessee. Anyway, let's talk about what arthritis is. It's a family of over 100 different diseases. We know that it involves the joints. We know that there's inflammation at various levels. And pain is basically present when you move the joint. There it is. This is a cartoon of the normal diarthrodial joint. And what you can see here is we have the joint space here. You have synovium lining the joint. That's what keeps that thick viscous fluid, the synovial fluid in there that acts like a lubricant. You have articular cartilage between them. You also have nice tendons and ligaments holding things in place. We know that in most arthritic diseases, there's some degree of disequilibrium of various cytokines. We know that there are pro-inflammatory cytokines, most notably TNF-alpha. You have interleukin-1, interleukin-6, IL-8, IL-10. You have all sorts of other growth factors, and what happens is they start to outweigh those anti-inflammatory ones. One of the things I've always, when I say that I've got 100 different diseases we're dealing with, they say, can you really prove that there are 100? And so just for fun, I threw a few of the more noticeable ones on there based by where they occur. Here's ones that are acute monoarthritis, and you can see this is just a bucket list of some of the diseases that can cause an acute monoarticular arthritis. In terms of chronic monoarthritis, you can see here we talk about Lyme disease and infectious related ones, and then you have a whole bunch that are non-infectious related arthritic diseases. In terms of the polyarthritis, you can have, this is just a few of the different causes of it. You see on here rheumatoid arthritis and juvenile arthritis, lupus. Believe it or not, people ask me, do I have arthritis or do I have lupus? The answer may be yes. And because lupus is an arthritis. Gout, vasculitis, sickle cell disease, osteoarthritis. There's a whole host of things that can cause a chronic polyarthritis. There are some of the more noticeable ones. These are probably the most common ones. In terms of intermittent arthritis, number one on that list is gout, pseudogout. You can see a palindromic rheumatism, which is sort of a precursor to rheumatoid arthritis, sarcoidosis, and so forth. Rheumatism, this is really separated from arthritis. This is more muscle, soft tissue based. They can be inflammatory, they can be neurologic, endocrine. There's a whole host of different reasons for muscle-based diseases. I think it's important that we try and come up with the right diagnosis. Number one, it's important that we have the right diagnosis so we can start the right treatment. We don't treat everything the same way. Early treatment can make a big difference, as I'll point out in a little while. And then also quality measures. In this day and age, we have to make sure that we've chosen that the patient's treated correctly and base the treatment on what that diagnosis is. For years, right now, the biggest question is, somebody asked me, when should I be referring a patient to a rheumatologist? And I think there are several reasons that are good. The last one is one that I've made a little bit different, and I'll explain why. Confirmation of the diagnosis. If you have a patient that comes in and you suspect they have polymyalgia rheumatica or something like that, that's something that's maybe you may want to say, yeah, is that what this is? Initiation of advanced therapies. Let's face it, you heard earlier in the pharmaceuticals about baricitinib. That's one that is a brand new treatment. It's the second one in that family. It's not one that you're going to be writing on an everyday basis. Third, evidence of inflammatory arthropathy. A number of studies have shown, as good as primary care people are, some of the diseases are better managed by somebody who has a lot of expertise because of the nuances, the subtleties of the diseases themselves. And then there's always that management of a difficult patient. The ones who really don't respond well to certain medicines, the standard treatments, may need a little extra push here and there. Patient reassurance was something that we used to use a lot. I used to joke that there were times when we treat the doctor and as well as the patient. Unfortunately, there's a problem with that now, and it has to do with the number of rheumatologists that are available. This is an interesting thing. This was a study that came out in Arthritis and Rheumatism just 2 years ago, and what they noted that here in the southeastern United States, in these states there is one rheumatologist for every 76,000 population. And unfortunately, it is estimated by 2030 that one will go up to 1 out of every 130,000 patients. Obviously, it's a tough situation. It's getting even worse because if you look at this, this is an estimated number of rheumatologists for the United States. And while the need for rheumatologists is going up, the number available to practice is actually going down. And there's a lot of reasons behind that, including training programs. Those of you who heard my big mouth yesterday morning talking to the deans heard one of the big reasons behind it. So I think one of the things we need to do is try and help. I want to be able to help you all try and get which patients should be seen by a rheumatologist and which ones maybe not needed to be seen by a rheumatologist. And so what I'd like to do is just give you a recap of basically how to evaluate the arthritic patient. Probably a refresher course for all of you since you have a lot of experience, but there might be a couple of little tips that might be of some benefit. I think in the assessment of a patient with arthritic disease, we have to go back to the basics. We have to start off with a complete history and physical examination, and then we choose appropriate laboratory studies and imaging studies. And I think each part of these is something that we really need to go back to the basics, science of that we learned a long time ago. First of all, the arthritic history, it's important to know, first of all, which joint is involved. That's important because some joints preferentially are more with one disease than another. How long has it been present? Is it something that started last week after I was doing all my yard work, or was it something that's been slowly growing over time? The rate of onset, has it been gradual, or did it hit you like a sledgehammer the night before? Any precipitating events, what relieves the symptoms, what makes them better? Is it present when you're doing things? That's an important question. The degree of morning stiffness, this can help us to separate the degree, because if it's something that has a ton of morning stiffness, that shows more an inflammatory disease. When are the symptoms the worst, in the morning or in the evening, and is there any swelling? The physical exam, again, you're trying to see which joints are involved. And again, by localizing the joint, that'll help us toward the diagnosis. Also, you want to see, when a patient comes in and says, oh, my hip hurts, where in the hip is that? Because that's an important question. In the knee, you want to find out, is it in the joint or is it more outside the knee, say where the pes anserine bursa is? Is the pain where the patient says it really is? I've had a lot of patients come in and tell me my hip hurts, and then I ask them, where is it? And they point way the heck back here in the middle of their lower back, and that's not exactly where the hip is. Is there any deformity or is there any change on the joint? And that's an important thing that can help us toward diagnosis. These are just some quick things to recap. This is a quick thing. I can tell you right now, as a rheumatologist, I get a stack every month of about 300 requests for referral. And my partner does the same thing. And it's amazing how many of them are sent for arthritis, and the joint exam is read as normal exam. So that's why I say it's sort of helpful to let us know where it is. Laboratory studies. Now, everyone loves to do blood work, and I think that can help us, but there are also a lot of pitfalls to the laboratory evaluating somebody with musculoskeletal symptoms. It should be based on the history and physical findings. It is not a screen. It should be based on what you're looking at. It's more for confirmation rather than for searching. And it can help to support a diagnosis, but it also can help to exclude. But it is not, none of the tests we have are 100% diagnostic, yes or no. Laboratory tests, ones we look at important. Number one, CBC. We know that the blood is a connective tissue. So we can tell a lot going on by whether there's anemia. We can see if there's a problem with the white cell count, platelet count. All these are clues to us. The rheumatoid factor, it's one that is very strongly associated with rheumatoid arthritis, but unfortunately, it does not necessarily diagnose rheumatoid arthritis. The ANA, we're going to talk about it in a little bit. Sedimentation rate, C-reactive protein, both of those are markers of inflammatory activity. And this new one at the bottom, the CCP antibody, we're going to talk about in a minute. The anti-nuclear antibody, this is probably the one that is used more than any other when it comes to assess a patient with a musculoskeletal symptom. It is a very sensitive autoantibody. It's seen in about 95% of people with lupus. As such, we get a lot of people who will come in and say, hey, I've got lupus because that lupus test is positive. However, they sort of overlook one thing. It's present in a whole lot of other diseases. And so it's not that good for calling it a lupus test. First of all, it has a very high false positive rate. And I'm going to show you some information about just how high positive it is. As we get older, we're more likely to have a false positive ANA. So if I see someone 25 with an ANA of 1 to 40, I'll take more notice of it than if I see someone who's 75 with an ANA of 1 to 40. It also can be associated with a whole host of diseases. It also could be triggered by medications. There are a whole host of medicines that can trigger a positive ANA. Please, one of the things, if you take home anything, it's not diagnostic of any disease, and it is not a lupus test. And so that's one thing to try and take home. This is the anti-nuclear antibody. As you see here, this is an immunofluorescent assay. This is the one that rheumatologists consider the gold standard for making the ANA. A lot of hospitals nowadays are using a ELISA test called a multi-light system. And most of us feel that it ain't worth a bucket of warm spit, if you want to be honest, because it has a lot of false positives, it has a lot of false negatives. The truth is there are over 150 different types of anti-nuclear antibodies, and only about 10 to 12 of them are a lot of clinical significance. That being said, the multi-light will take 8 of the more common ones, and that's all they'll check for. In other words, you could have a ton of false negative anti-nuclear antibodies. In terms of things, it can be seen also in normal patients. Here's some interesting data. Let's see if I can get there. From India, the study took 32,000 samples. 12.5% were positive. And that's just everybody. At the same time, you can see here, there were 4 cases per 10,000 population that really had lupus. In other words, there was probably, for every person with lupus, there were probably 120 people that did not have lupus. In Germany, if we go into Europe and look at more of the Caucasian people, here's one, it was just published last year. And out of 1,200 people, 33% of them had an ANA of 1 to 80 or higher. If you look at, if you're looking at some of the other ones, 29% had 1 to 160. Then you get up to the 1 to 640. 2% had 1 to 1280. So it's important to realize when we see someone who has that ANA of 1 to 40, it probably isn't of any clinical significance. The rheumatoid factor is another one we use. As I said, 80% of people with rheumatoid arthritis have a positive rheumatoid factor. But there are a number of other diseases in which you can see a positive rheumatoid factor. Lupus. Sjogren's syndrome is important because while 80% of people with RA have a positive rheumatoid factor, 90% of people with Sjogren's do. So it actually maybe should be called a Sjogren's test rather than that. There's a number of things, cryoglobulinemia, vasculitis, are all factors that can be seen with a rheumatoid factor. In terms of non-rheumatologic diseases, a number of these are also positive. I've had patients sent with some of the strongest positive rheumatoid factors. And when I start asking them some questions, I start to also see liver enzymes. And we've picked up half a dozen cases in every year or so of hepatitis B and hep C. Because hepatitis C can often trigger a positive rheumatoid factor. That can be your first tip-off to look for it. So if you see someone who has a little joint ache but doesn't have hot, swollen joints, but has a positive rheumatoid factor, make sure you get a history to see if they could have a risk factor for hep C. This is a newer test, the cyclic citrullinated peptide antibody, or CCP. This has been around now for about 10 years. It's a test that we now recognize is far more specific for rheumatoid arthritis. Not only is it more specific for rheumatoid arthritis, it's also more specific for aggressive rheumatoid arthritis. And what's interesting, it may start to be present as much as 3 to 5 years before full-blown rheumatoid arthritis develops. So if I see a patient comes in, and so what I say is if you have somebody who has a little bit of joint pain and a little achiness and they have a positive CCP antibody, that's somebody we want to take a look at because they could be in the process of developing rheumatoid arthritis. If you look at what we're talking about, the positive CCP antibody, no, I covered it. That's a whole other thing. Okay. Anyway, the CCP antibody is so much more predictive of developing rheumatoid arthritis that it's one that every rheumatologist in the country is going to take a lot of serious notice. And it isn't just a little bit positive, but I mean the ones that are so high it can't be measured. This is an interesting study that was done, and what they saw, and this was presented about 15 years ago, they took 80 early RA patients, and what they saw, they were former blood donors. They basically went back, got these patients' serum when they were donating blood and looked for the CCP antibody and was able to sort of follow them. And they saw that after 5 years, or after 10 years, there was about a 70% chance of them developing full-blown rheumatoid arthritis. So this is a better screen, in my opinion, for joint. If someone has joint pain and it's going along and some stiffness, doing CCP antibody will give you a lot more bang for your buck when it comes to identifying patients early. Yeah, Phil.
Do you know how many bucks we're talking about for a test like this?
Oh, it's under $100.
Okay.
It's not expensive. Yes, yes.
For those patients you said that have the RF as well as the hep C, did you end up finding a lot of cryoglobulinemia?
Well, that's a good question. I think that that's where a lot of it does develop. The people with a positive rheumatoid factor and hep C are the ones that are far more likely to develop cryoglobulinemia. I don't usually check for them unless they're having problems, though. But I think it's something to keep in mind when you have them. All right, imaging studies. I think it's important to base your decision on whether you're going to get joint x-rays or whatever based on the history and physical findings. You want to try to choose the right place. As I was saying, I've seen patients who walk into an emergency room and they say, I've got hip pain. So what do? Get a hip series. They don't even bother to find out where in the body it is. And I've had so many patients who had normal hip. They said, my hip really hurts and it's back in the gluteal region. And so it's important to try and identify, are you x-raying the right spot? And it also is good for confirmation and for determination of severity. We shouldn't be using the x-ray purely for a diagnostic purpose. Plus, plain x-rays, they can be diagnostic in terms of late disease, but in early stages, it's not going to help. I'll give you a good example. I've had a lot of patients who are concerned about ankylosing spondylitis, which is an inflammatory condition of the lower back especially. If we wait until we see the sacroiliac changes, they will have had it for a good 10 years, and so it's not all that helpful. And it's important to realize x-rays, they show anatomy and architecture, they don't show pain. And so it's important to realize the limitations of these. MRI and ultrasound, this is something we're using a lot more. I was listening very intently this morning to the POC talk, to be honest with you. And we are now using musculoskeletal ultrasound a lot more in rheumatology because of the fact that we can identify inflammation, we can identify swelling, we can see is it due to, you can see erosions long before it shows up on x-rays. MRI is another option, but it ain't cheap. And so, I mean, compare a $100 ultrasound of the hands to a $2,000 MRI of the hands, it's a lot easier to get the hand ultrasound. In terms of treatment for our patients with arthritic disease, the first thing we want to try and do is treat early. A lot of our diseases are destructive. They're erosive. They can cause permanent, irreversible damage. And so the earlier we can identify the patient and get started on treatment, the better for them. In terms of trying to treat, we want to try and limit the amount of pain, the amount of joint damage, extra-articular problems, disability, and premature death. And finally, at the very worst, we want to try and give not just palliative, but ameliorative therapy. And so that's what our goals are in rheumatology. It's important to base it on the right diagnosis. And that's why I say we want to try and identify. This is just an example of some of the diseases, and you'll notice something interesting. We don't treat everything with prednisone. And so we do try and come up with the right treatment for the right disease. And we've seen a lot of advancement in what we treat, and that's sort of an exciting thing. I think what I'm going to do is I'm going to go on to a couple of different diseases now. And, oh, by the way, I forgot to mention this. One thing that's nice to know, we do not like smoking in rheumatology either. Believe it or not, there are studies that show that cigarette smoking not only increases the risk of arthritic disease, but also can deter the response to the medications. An interesting study was done in Sweden. They looked at all the rheumatoid arthritis cases, and they identified that 1/3 of all the cases of rheumatoid arthritis were triggered by cigarette smoking. And so it's an important commodity when you have patients to really explain to them this is why you really don't want to smoke if you have an arthritic problem. Now, let's switch over to some diseases. A lot of people have troubles understanding whether they have, the patients coming in with rheumatoid arthritis or osteoarthritis. There's been some people, primary care people who will say, well, if it's mild, it must be osteoarthritis. If it's severe, well, that must be rheumatoid arthritis. And so I think it's important to try and understand how we can separate these two diseases. By definition, rheumatoid arthritis is a symmetric inflammatory polyarthritis. It is an erosive disease. It's more often in women. It also can hit at any age, though we have a bimodal pattern. A lot of times we'll hit it in the 30s, 40s, then we see it in the 60s, 70s. There are a lot of clinical features that show up, and it's all related to pro-inflammation cytokines. We don't know what triggers it. There are a lot of theories behind that. There's genetic predisposition, the HLA-DR4 antigens, those of you who are wanting to know for your boards coming up. Regulatory and psychological stress plays a role. Hormones plays a big issue too because of the fact we've actually seen some changes in things related to pregnancy as well as use of birth control pills. And so that's changed some of the course on this disease. The clinical presentation of early rheumatoid arthritis looks like this. The hand's got some redness here and maybe a little swelling. Over time, now this is the natural history. This is not what this is if we don't treat it. We start to see more swelling, more deformity, and finally we see the classic findings, which includes anterior subluxation at the MCP, the ulnar drift. We see this patient even has rheumatoid nodules there. The carpals are often involved, and you can see here there's the damage of it. You see a lot of erosions on the side of the joint. You see periarticular osteopenia. And what you'll notice here, the carpal bones, they're suddenly just fused together. So this is a pretty nasty disease. The progression of RA starts off with just some pain, some swelling right at the MCP joints, especially, and in the carpal joints. We'll see redness and stiff, the classic triad of inflammation, or four pieces. Then what happens is we see rapid progression in that we start to see formation of a pannus right at there, and it's in the synovium. If you remember from that cartoon at the beginning, synovium is only about 1 or 2 cell layers thick. In rheumatoid arthritis, it rapidly progresses to its hundreds and hundreds of cell layers thick. We start to see vascularity in that tissue. We start to see the fluid in the synovium becoming much less viscous, and it's more watery, and it becomes a lot of protein in there for inflammation. Eventually, we start to see erosions develop. We start to see capsular stretching. We see articular destruction. You can actually see tendon rupture. I'll have a patient come in and they say, I'm doing fine, except I can't raise my finger like this. And that's one of those surgical urgencies if they haven't had it, if they've, not had it for more than 2 or 3 months, which is unfortunately one of the problems I have. When we try and identify who has rheumatoid arthritis, some call points. Number 1, joint stiffness in the morning, and it's prolonged. It does, we all feel a little stiff in the morning after we get up a few years, but this is lasting 2, 3, 4 hours. We will see specific involvement. Basically, if you look at the MCP joints, across the carpals, and maybe some of the PIPs. It doesn't hit the DIPs as much. In terms of, it's also a symmetric pattern. We hit the same joints on the left side and the right. It is a whole body disease. It's not just a disease of the joints. As such, we can see fatigue, we can see fevers, we can see anemias, we can see generalized malaise, and it's one that can last for years and it can progressively worsen over time. Tests for it, as I mentioned, the rheumatoid factor, we've already gone over that, and the CCP antibody. These are very, very helpful later on, and they do help us, especially the CCP antibodies, identifying those patients. Now, this is just a list of the treatments for rheumatoid arthritis. When I first became a fellow, about the only ones we had available were methotrexate, azathioprine, that one, and gold salts. That was it. And so this has been a burgeoning area. We are so excited in rheumatology that we have this list of medications. You heard about one this morning, baricitinib, which is right there. There are about 3 or 4 other JAK inhibitors that will be coming out probably within the next couple of years. There's also ones that are SIK inhibitors, and there are a number of other classes that are coming along. We're all excited in rheumatology because, we actually have something that we can make a difference in this disease. And it's important, the earlier we get started on them, the better. Let's switch to osteoarthritis. Osteoarthritis is by far the most common arthritic disease. And this is one that it generally affects older individuals, and I say that tongue-in-cheek because of the fact if you do x-rays on every man and woman on their 40th birthday, half of them are going to have osteoarthritic changes at some point in their body. It is characterized by the loss of cartilage. This is where the joint occurs. It's mostly hip, where you have joint bone versus bone. It's not bone versus bone. You've got cartilage on each end. That's where the focus of this disease is. There can be localized inflammation. And so it is not necessarily just wear and tear. It worsens with weight bearing and with activity. And there is some morning stiffness, but it's usually short-lived. And they also often have a thing called a gel, what we call the gel effect, which is if you let them sit a while, they'll get up and they'll be really stiff again it takes a few steps to loosen up. The diagnosis of osteoarthritis, looking at the location. It's more in the DIP and PIP joints, also the first CMC. If the first CMC is involved, that's osteoarthritis in 9 times out of 10. That really helps to separate. Other places that get it, the weight-bearing joints, the hips, the knees. The duration of stiffness is a lot shorter. On physical exam, there may be some bone growth. Often you'll feel crepitus when they move the joint. Here's a nice hand x-ray, to show you where it is. You'll notice these lovely little nodes here. They're Heberden's nodes. They were named for Sir Edward Heberden, who was a medical doctor in England in the early 1900s who wanted residents to remember his name. Henri Bouchard gave us these, which are the PIP joints, who is also known as Bouchard's nodes. You'll notice here also a little change here at the thumb joint. You notice it doesn't fully come out. That's squaring of the first carpal metacarpal joint. That's another real strong diagnosis for osteoarthritis. And in fact, the first CMC is probably the most common site for osteoarthritis in the hand. It does not normally affect very much the MCPs, and it really doesn't have the effect on the carpal bones in the hands. When we make the diagnosis of osteoarthritis, first of all, the labs are pretty much unremarkable. There's not a lot of inflammation. The CDC is normal. Seborrheic CRP are generally pretty normal. If you get fluid on the joint, it's not a real high cell count. Radiographic, you start seeing osteophyte formation. You see joint space narrowing. Now, there can be an inflammatory component to this disease, so don't just say it isn't, that's purely wear and tear. And going in terms of treatment, that's an important thing to keep in mind. How to separate rheumatoid arthritis from OA. First of all, rheumatoid arthritis is a whole body disease as opposed to osteoarthritis, which is usually a lot more localized. The pain may worsen as the day goes on in osteoarthritis. Can contrast that to rheumatoid arthritis, where it's there all day, may get a little better, but it's a lot everywhere else. OA may be more asymmetric. You can see much more in the dominant hand rather than the other hand. And so I can pick off a lot of times. The patient will come in with a lot of hand problems, and I'll ask them, are you left-handed? And they are, yes. And so you will see it more in the dominant hand. In terms of, let's see, go on. There we are. And just again to review, this helps to separate RA from OA just by looking at the hand. First cover metacarpal joint, VIPs, PIPs, think more OA. If it's in the MCPs and in the carpals, think more rheumatoid. Medical treatments for osteoarthritis. Now I'm giving you some stuff that just came from, I was at our ACR meeting last week, so I can give you a lot of hot stuff. I'll probably anger one member of the room today because of what I'm going to say. Analgesics are big. We talk about trying acetaminophen. Most rheumatologists don't like to go above 2,000 milligrams a day. The problem is there's a lot of times where there's inflammation in these patients, and that's when we start looking at the non-steroidal anti-inflammatory drugs. We know they have risks. We know they've got a lot of problems with them, and so it does make it hard to use. We try the lowest dose we can first for the anti-inflammatory drugs. If we have to, and it's an older patient, I still think celecoxib is a good alternative. I think the COX-2 specific, the COX-2 inhibitors are safer on the stomach. I think they are the only things I would use in someone on anticoagulation. I would not use Advil or Aleve in someone who is on any of the medicines for coagulation. Advanced pain medicines, tramadol is one that we do use. It's one that I think is safer. And you'll notice we don't jump right away to the opiates. And there are other medicines that might be of some benefit. Sometimes duloxetine, which is FDA approved for chronic back pain and for osteoarthritis of the knee. This might be worth considering. Some patients have a neuropathic component to their osteoarthritis, and we will use off-label gabapentin and pregabalin. That's a sorry about the typo there. Non-pharmacologic treatments, weight management. It's important to get your patients to understand, especially on the knees, weight plays a big role. For every pound you weigh, 5 pounds of stress goes through the knee with each footstep. 10 pounds of stress goes through the foot and ankle. So the good news is studies have shown that just losing an average of about 12 to 15 pounds reduces the progression of osteoarthritis in the knee by 50%. And so that's an important thing. Exercise, I think exercise is a great way to go. It strengthens the muscles around the joint. It really makes a difference. There was a study done a number of years ago where what they had patients do that were getting ready to go in for knee replacements, sent them for an aggressive knee exercise program. And so they was all randomized, half of them went in, half didn't. And when they finished the study, they found that all the people that were in the aggressive exercise program did better. They were out of surgery better, they were back on their feet better, and everything else. 2 of the patients in the exercise program actually dropped out of the study because they did so much better, they decided not to have their knees replaced. So a good knee exercise program will be a big benefit to your patients. And in fact, when we were actually at our ACR meeting, they were saying that the patients who do get into a good physical therapy program may actually be one of the best ways to go with treating osteoarthritis of the knee. Other things, pacing yourself. A lot of times I have patients say it hurts when they do something for an hour straight, and my answer to them is, don't do it for an hour straight. Do it for a half hour, stop, rest, give the joints a chance to recover, and then you can complete it. Here's the fun part. When do we send patients to an orthopedist? First off, if the joint needs to be replaced, we'll tell them they need to see the orthopedist to let them consider if it's time. If a patient comes in dragging their leg behind them because they can't walk, it's probably time to take a look at it. Arthroscopy is getting a more and more hot issue. There was a study that was presented from Harvard over at our meeting this last week that literally was talking about comparing arthroscopic meniscectomy versus physical therapy. And at 5 years, they could not see much difference between the 2 groups. And so I think there's a lot to be said about whether a patient benefits from meniscectomy. What's interesting, the group that had the meniscectomy, a lot more of them ended up having to have knee replacements. And so, that's a lot. Yes?
That's very accurate, and a lot of it depends on the type of care you have. And
I agree.
For sure, the lateral compartment, you want to not touch the 10-foot hole almost unless you got, if your knee's locked and you got a bucket anal tear, there's not much you can do. You got to do something to help.
Mm-hmm.
But, our experience is, is that, bottom line, particularly degenerative tears, you're way better off walking on a sock that has a hole in it than not having a sock on at all. So, when you go taking out degenerative tears, that just progresses people to, but there are a few kinds of tears that are amenable to fixing, but for the most part, you're right, it's falling more and more out of vogue, and that's our literature too. Opinion with that.
Let the record show that there has been consensus between the orthopedist and the rheumatologist. So,
Collaboration.
hey, what can I say? Yep, collaboration, exactly. Anyway, I think there are some other times. There are times when we will use an orthopedist because if the patient has such an overgrowth of the synovium in certain diseases, getting an open synovectomy can actually help save that joint. Arthritis is something for certain joints they don't have good replacements for, and so I do think that that's something worth, that's where they talk to the orthopedist about. Physical medicine and rehab is also an important component. I think this is where we are leaning much and more in terms of patients with osteoarthritis. Getting them into a physical therapy program where they can be educated in a good exercise treatment program makes a ton of sense. When we talk about seeing, when does the patient with OA have to see a rheumatologist? Well, first off, if there's some problems that they're not a surgical candidate, often going through a pain management or a rehab also may be of some help. Physical medicine is a great option too. Also, if they have complicated treatment, and if there's some question, could there be an underlying inflammatory component to their RA or to their OA? Let's switch to the ANA family of diseases. This is one that a lot of people have troubles because, like I said, the ANA is so pervasive in our medical area that people get it all the time. The ANA, obviously, the hallmark of the diseases is lupus, but then it also is associated with a whole host of other diseases, including polymyositis, dermatomyositis, Sjogren's syndrome, scleroderma. There's a whole host of diseases in which an ANA can be positive. I want to focus on lupus because that's the one most patients, they go to Dr. Google and they've got a positive ANA, so they are sure they have lupus. We had a patient that actually went to, and came in and says, I know my ANA is negative. I know that you've told me my labs are all normal. I know my exams are all normal, but deep in my heart, I know I have lupus. And so this is the kind of patient a lot of, I'm sure, you all will face. Lupus is a multi-system disease, seen more in women, more in African Americans, about 9 times as common in African Americans as it is in Caucasians. Its incidence is anywhere from 1 in 500 to 1 in 1,000. The 1 in 500, I would say that's more with African Americans. As I mentioned, it's more often in them. Let's see. When do we consider a diagnosis? Number 1, it's seen in women often with childbearing age. Constitutional symptoms of fever, weight loss, malaise, fatigue, rashes, arthritis, renal disease, and so forth. You'll notice that it doesn't say anything about fatigue alone. An ANA is really not a good test to be done just to assess for fatigue. You really need to have some of the other findings, and that's where the ANA comes in handy. This is something that was given to me. This is about to be old and outdated. This is the 1990 ACR diagnostic criteria for lupus, and it is a mnemonic that goes by SOAP Brain MD. This is a very easy way to remember some of them. For someone to go into a research study on lupus, they need to have 4 of these, including evidence of anti-nuclear antibody and or other immune studies. And this is a great way to look because I'll be honest with you, I use this very quickly to say why a patient doesn't have lupus. Because if they have an ANA but they don't have any findings of inflammation, pleurisy or pericarditis, the ulcers in the mouth, the arthritis, the photosensitivities. Patients with lupus quite often are so sensitive to the sun that fluorescent lights make them sick. Blood abnormalities, as I said, blood's a connective tissue, so it's important to look for signs of anemia, signs of low white count, low platelet count. And then you have the 2 rashes at the bottom, the malar rash and the discoid lupus. In terms of autoantibodies, the ANA is the one that we know about, but these are some of the specific ones that also point toward lupus. The double-stranded DNA is very specific for lupus. It is highly associated with lupus nephritis. The anti-Smith also is specific for lupus, especially with the renal disease and lung disease. Anti-ribosomal B protein is one that we strongly suspect are watching for lupus cerebritis. And then last but not least, SSA. This is a Sjogren's antibody. It used to be called Rho. Anti-SSA is one that we see in people that are ANA negative lupus. It's also present in the patients who have cutaneous lupus. And so if you have someone who has a lovely malar, has the rash, but they're negative for the ANA, check an SSA because they may have a cutaneous lupus to keep up in mind. I'll let you write a second. All right. This is some of the associations when it comes to lupus and drug-induced lupus. I put this in here because of this one here, anti-histone antibodies. There are a lot of patients who we get, they check to see do they have drug-induced lupus and they have a positive histone. Histone is not diagnostic for drug-induced lupus, but just about everybody who has a drug-induced lupus has the anti-histone antibodies. Medicines to think about are some of the ones like Quingalut, and there are several, apresoline, several of the medicines, and the heart doctors love to use medicines that trigger lupus. And so keep that in mind. Treatments for lupus. The cornerstone of treatment for us is hydroxychloroquine. Plaquenil is considered the best treatment. We normally now are trying to get away from going above 5 milligrams per kilogram per day. There was a very interesting debate at ACR between an ophthalmologist and a rheumatologist about the dosing and the risk on the eye. We do try to minimize the eye risk, and so that's why we're trying to, if we can get away with not using a dose above 200 milligrams a day, we try not to. Most patients, unfortunately, do need 200 twice a day. This is a medicine that reduces the need for corticosteroids, and it reduces the need for the immunosuppressants. Immunosuppressives, the ones we've used, azathioprine, mycophenolate mofetil, and methotrexate. You'll notice that cyclophosphamide is not on there. We'd rather not use it because of the fact that what we're looking at is a population of young women, childbearing age. A lot of them don't want to take a medicine that has the risk of rendering them infertile. And so that's why we try not to use a lot of cytoxane. Belimumab, this is a biologic agent. This is the only one that's FDA approved for lupus. It works through a B lymphocyte stimulator, or BLIS. We sort of like saying we're giving you a BLIS medicine. Rituximab is not FDA approved. This one goes against activated B cells, and in the original studies, it did not breach their endpoints. What's funny is after they did not get an FDA approval, the company went back and looked at the data, and they saw that it reached a lot more endpoints in the Caucasians than it did in the African Americans. So a lot of our patients with lupus that are Caucasian, we may actually use Rituximab. And then finally, last but not least, is corticosteroids. You'll notice that the corticosteroids are way down here at the bottom. They're not at the top. One of the top experts on lupus is a lady by the name of Michelle Petrie. She's at Johns Hopkins. And one of her favorite sayings is that it's not a coincidence that prednisone and poison begin with the same letter. And so we do try not to use a lot of prednisone in patients with lupus. If we can get away with it, we may use it short term, but it's not something we want to use long term if at all possible. I'm going to switch to another diagnosis. This is one that I really think every primary care physician should be able to manage. And this is gout. This is one of my favorite quotes on gout. And it was by a minister back in the 18th century, or 19th century, which is sort of fun. This is what gout is. Gout is this acute inflammatory attack, and it's usually in the foot. And that's what classic podagra looks like. And gout, let's go for some definitions on gout, because there's a lot of people that sometimes get a little hazy on this. Uric acid, obviously, is the end product of the purine acid metabolism, or purine metabolism. Gout is the disease state in which you have the acute attack. Gout is not a high uric acid. That is something different. The thing is, what happens is the uric acid crystals get deposited in the tissues. They trigger an intense inflammatory reaction, and that's what the gout is. Hyperuricemia, that's when your concentration is greater than 6.8 milligrams per deciliter. And it doesn't mean you have gout if you have a high uric acid. It means you have high uric acid if you have hyperuricemia. And it could be due to either hyperproduction or underexcretion. And so it's important to come up with which form it is in some ways. It may not show up with symptoms. Most patients who have hyperuricemia, it's a benign thing. They don't have attacks. It's those who have attacks that we really need to address. A sad truth is, the reason I'm bringing this up and why I think it's important to go over is, at our ACR meeting, they said that less than 35% of people in the United States who have regular gout attacks are not on any treatment to lower their uric acid. So that means 2/3 of patients with gout, basically, take that back, it's 35% are treated. So it's 2/3 of people with full-blown, long-standing gout are not on any medicines for that disease. And that's a bad situation. Some things to keep in mind. First, you have the asymptomatic hyperuricemia, and that's just elevated uric acid. We used to pick these up on the executive panels back when we were young, before they took uric acid off of the CMP. There is some studies that are suggesting they may bring the CMP back and include the uric acid in it, but that's because of cardiology and because of a whole host of other reasons. Acute Gouty attack, there's acute inflammation that's triggered by the MSU crystals. Then there is intercritical periods. This is the time between the attacks. That's important because that's the best time to check when the uric acid is elevated. And then you have advanced gout. These intercritical periods become shorter and shorter and shorter until you finally can develop full-blown chronic gouty arthritis. Basically, overproduction of gout. There's some genetic reasons and idiopathic. Sometimes you take in extra foods, organ meats and sea shellfish, the things we all like to eat. Those are what have a ton of uric acid in them. There are also alcohol abuse, especially beer. Beer has a big thing that gets your uric acid levels up. An interesting little piece of trivia, I don't know if it's in here, but believe it or not, milk lowers your uric acid. Skim milk is so if they really want to do it, go with the skim milk. The acute attack, this one is so bad. That's the trip-off. Not everybody with foot pain has gout. But if someone comes in and they say that sheet hurts to touch it, that's invariably gout until proven otherwise. I've heard patient after patient say that. It often starts at night. And if you think about it, the reason is, in the foot, is because your feet are usually a little colder than the rest of the body. The maximum solubility is 6.8, and that's at 98.6. You drop the temperature down to 94 or 95, that maximum solubility drops to 6.0. And so that's why it more often preferentially hits the feet, which are the cold areas. 75% of the first attacks are in the big toe. And during the attack, that's not the right time to check your uric acid. The time to check it is during that intercritical period, because during an acute attack, the uric acid level may be artificially lowered. And so that's a little bit of a tip-off. This is what a tophus looks like, and you see this little thing. When you push on that, they'll get what looks like Pepsodent toothpaste coming out of that thing. It's not a nice view. And under the microscope, these are what the crystals look like. They are gorgeous if you want to look at it on a microscope. It's fun to show the residents. It's not fun for the patient, but it's fun to at least show them. They're beautiful. The birefringence you can see here, you'll notice that in some direction they're blue, and in some direction they're yellow. That's what the birefringence refers to. When they're 90 degrees to each other, they're different colored under a polarizing lens and a red filter. The goals of treating gout. Number one, first and foremost, is stop the acute attack. When a patient is in such agony, that's one of the things we want to try and do that really well. Second thing we'll aim at is trying to protect against recurrent attacks. And then finally, we want to address the hyperuricemia. All three of these components need to be looked at, and each one is different. In terms of treating the attack, you're not out there to try and cure the gout. You're trying to stop the inflammation. And so there are several medicines that are approved. First one, non-steroidal anti-inflammatory drugs. Several medicines are approved for it. They do a pretty good job. The problem is, if you look at the patients who have gout, they're usually the overweight, high blood pressure, diabetics, and they have maybe some renal problems and everything else, and they're older. They're not the best choices for NSAIDs. Indocin is sort of hard on the kidneys, and so it's one that I'm not very happy with. Colchicine. Now, colchicine is still FDA approved. A few years ago, a company took the study, and they did an interesting thing. They compared the every hour on the hour until their attack gets under control, or else they stop. And they found that those patients invariably, they compared that to 3 doses in a 24-hour period. They found that 3 doses in a 24-hour period did just as well and was better tolerated. As a rheumatologist, I think the only person I would ever consider writing to take colchicine every hour on the hour until their attack stopped was somebody I really, really hate. Do not give more than 3 doses in a 24-hour period. The third option is corticosteroids. Now, this is a dirty secret among rheumatologists because I was at a big meeting discussing acute attacks, and we were in a room where half the people in there were rheumatologists and half were primary care. And the moderator asked the room, how many of you use corticosteroids for stopping a gout attack? And about half the hands went up, and I looked around and it was all the rheumatologists. I think that this is probably, in many cases, the least bad choice. And because if you look at the other ones, colchicine does have stomach upset and so forth. NSAIDs have a lot of problems in and of themselves. The corticosteroids do quite well, they work, and they can quite often be the least bad choice for helping with a gout attack. And I think you have to look, you want a rapid onset, and that's where we'll give the depomedrol, and it gets into them pretty quickly. And duration is a treatment's a big issue. Preventing flares. What you need to be doing is looking at something for prophylaxis. This is where colchicine comes in handy. Most of us don't use a lot of colchicine for attacks. We will use it for prophylaxis. When you are starting urate-lowering therapy, they're going to want to use colchicine as once or twice a day. That helps prevent further attacks. Low-dose NSAIDs and low-dose steroids, and that's what you want to try and do. Then you want to try and treat if they're having gout attacks, and that's where going with the urate-lowering therapy is the important thing to do. Our goal is to get it below 6. The reason is if you have a patient who has a gout attack and they have a uric acid of 9, they're about a 5% chance of attack. They have about 80% of another attack. We are aiming for under 6 if they have tophi or kidney stones, under 5. And so that's an important thing to keep in mind. In terms of treatments, the first 2 we don't use a lot. We use allopurinol the most now. Start low. Don't start with 300 milligrams a day. Start with just 100 milligrams a day and then slowly increase. Do a basically treat to target. Don't just give them 300 and say, okay, that's good enough. Believe it or not, rheumatologists are pushing this drug up to 800 milligrams a day if they have good renal function. You can actually use allopurinol in some patients with lower creatinine clearance in the 40 or 50 range. We found that it's okay to use it. But I think you have to push the dose up to get it down. Febuxostat is for people with pretty significant renal insufficiency. Pegloticase, this is a biologic agent that does a great job of getting the uric acid down to 0. The problem is it is highly immunogenic. And what we do is we literally check the uric acid on the day that they're getting it to make sure that they aren't, that it's not come to normal, because if they do, they're going to have a hypersensitivity reaction. Just a couple minutes on fibromyalgia. This is one that everybody, I'll be done quick, I promise. Anyway, fibromyalgia is one of bringing sleep disturbance. I'll tell you what I'll do is I'll go on to the treatments, because I think that's the biggest question people ask us. Management, first of all, non-pharmacologic is one of the most important things. Doing a regular exercise program is one of the best things. Cognitive behavioral therapy is another way to look at. At ACR, a friend of mine, Leslie Crawford, who is chairman of rheumatology at Vanderbilt, has done a new study on TENS units in fibromyalgia patients, saw a lot of success. She's planning to get it published within the next year. In terms of medications, analgesics, opiates are not a good choice in fibromyalgia. Period. Do not use them. They don't work. And last but not least, in terms of it, the SNRIs, milnacipran and duloxetine are both FDA approved. I'm going to close by telling you all a little story, and this is one that's sort of important to me. A few months ago, I had a patient come in, and I did my good history, good physical exam. And afterwards, we sat down, we went over things. I talked about what I thought could be going on, and I said, let's find out what's going on so we can come up with the right treatment. As we're walking down the hall, he left me speechless, which those of you who know me is a shock. He says to me, Doctor, I want to thank you for being a doctor and not a prescriber. And that's really hit me, because that's the way we all need to be. And so my admonishment is, one of the most important things is the word doctor comes from the Latin docere, which is to teach. And so I think one of the things that we can do a lot better is we all do follow my recommendation to my patient and to be a doctor, not a prescriber.